Good day, and welcome to the third and final installment of the Cranial Nerve podcasts. Once again, this is Dr. Stuart Ingalls. In the last segment, we went through an in-depth discussion of the first 6 cranial nerves and their respective functions. We conclude this discussion with a look at the last 6 pairs of cranial nerves. Now, this is going to take us deep into a discussion of autonomics of the head and neck, and it'll be necessary to revisit the trigeminal nerve to make sense of it all, so this is going to be a long one. May even want to try watching it in segments rather than all at once. But hopefully, by the end of this discussion, the nebulous that is the autonomics for the head and neck will be much less of a mystery. So once again, a reminder that all of the material used in this video is either licensed through the Creative Commons or is considered part of the public domain. As a result, this video is completely free of copyrighted material and can be circulated without restrictions. If you find it useful, feel free to download and circulate with my blessing. I've also included a link to download the PowerPoint presentation that this podcast is based upon, which can once again be distributed and used in whatever capacity you choose. We pick up our discussion right where we left off with the facial nerve. We saw this in the previous podcast as a small branch that passes through the internal acoustic meatus. Once in the petrous bone, things get a little complicated. We'll start with the most straightforward division of the facial nerve, and this is the motor division. It winds its way through the petrous portion of the temporal bone to emerge through the stylomastoid foramen. Almost immediately, it gives off the posterior auricular branch, which runs dorsally between the external acoustic meatus and mastoid process to supply the occipitalis and some small muscles related to movement around the ear. 2 other small motor branches, to the posterior belly of the digastric and stylohyoid, are also seen branching at this point. The principal root of the facial nerve next winds laterally, then anteriorly through the substance of the parotid gland to enter the face. While it's still in the gland, it starts to divide, first as superior and inferior branches, but ultimately as the 5 terminal branches that innervate the muscles of facial expression. The temporal branch innervates, among other things, the frontalis and orbicularis oculi muscles. The zygomatic branch is next, which also provides innervation to the orbicularis oculi, as well as the zygomaticus major muscle. The third of these anterior branches is the buccal branch. If you remember back to when we talked about the trigeminal nerve, there was a buccal branch from V2 that was sensory to the mucosa of the mouth. As we're seeing with all of these extracranial branches of the facial nerve, in this case the buccal branch is motor, supplying over a half dozen muscles in the mid-region of the face, including levator labii, buccinator, and orbicularis oris muscles. Next, the marginal mandibular branch courses along the external surface of the mandible to supply the depressor labii inferioris, depressor anguli oris, and mentalis muscles. And finally, the cervical branch supplies the platysma muscle of the anterior neck. Although numerous, the extracranial branches of the facial nerve are pretty straightforward to follow. In contrast, the intercranial branches are fewer in number, but tend to be more difficult to conceptualize. This is probably because they take some tortuous paths to reach their destination, and many of these paths are encased in the bony elements of the skull and are obscured from view. It's reminiscent of the secret passages in and around Hogwarts that Harry Potter used the Marauder's Map to help navigate. We don't have a Marauder's Map ourselves, but hopefully through a series of carefully selected images, we can still get across what is happening. On the far left, we have the image of the skull used in the previous podcast session. Remember that the facial nerve crosses over and exits here, through the internal acoustic meatus. At this point, we lose sight of its path and must trace the path being taken through the facial canal under the petrous portion of the temporal bone. Initially, the facial nerve courses anterolaterally, but then takes a relatively sharp bend to run posterior to the middle ear. It then curves down to exit through the stylomastoid foramen. We can trace this path once again using a few additional representations. Here's a magnified image of the temporal bone with the superior petrous portion removed. Again, we can trace the course of the facial nerve as it traverses this canal. Here we have 2 more images. One is a coronal cut to show the nerve as it runs laterally. The other is a parasagittal cut showing the nerve just lateral to the cochlea. Hopefully the combination of these 3 separate views will help you in generating a 3-dimensional image in your mind. Note that at the initial bend within the neural path, the nerve enlarges due to the presence of a ganglion containing cell bodies, which we will discuss momentarily. Because of its resemblance to a knee, this segment is referred to as the geniculate ganglion. We're going to focus on two specific intracranial branches. The first is referred to as the greater superficial petrosal nerve, which is often just called the greater petrosal nerve. Notice its location in each of the respective images. This branch arises at the initial bend around the spot of the geniculate ganglion and contains presynaptic parasympathetic axons, as well as a few taste fibers as well. It re-enters the middle cranial fossa through a small opening called the hiatus of the facial canal and runs anteromedially inferior to the trigeminal ganglion. At this point, the greater superficial petrosal nerve dives through the foramen lacerum, containing the internal carotid artery, and fuses with the deep petrosal nerve, which contains postganglionic sympathetic fibers branching from the superior cervical ganglion. The fused branch now contains both sympathetic and parasympathetic axons, which courses through the pterygoid canal within the medial pterygoid plate to enter the pterygopalatine fossa. As a result, this fused branch is often called the nerve to the pterygoid canal, or most simply, the Vidiian nerve. To trace the autonomics to their endpoint, we must return to an earlier diagram in which we discussed the maxillary branch of the trigeminal nerve. Once again, we observe the facial nerve in the facial canal, this time on the left side of the body, and the greater superficial petrosal nerve fusing with the deep petrosal nerve to enter the pterygoid canal as the Vidiian nerve. This is another one of the nerve branches that enters the sphenopalatine ganglion we discussed earlier. This serves as a point of synapse for the parasympathetic fibers originating from the facial nerve. So now we know what kind of cell bodies are located in the sphenopalatine ganglion: postsynaptic parasympathetic cell bodies stemming from the facial nerve. Both parasympathetic and sympathetic postsynaptic fibers then exit the sphenopalatine ganglion with a number of destinations in mind. Remember, we think of the sphenopalatine ganglion as being like O'Hare Airport, with a number of different things coming in and then branching out together in a variety of directions. Some fibers course through the nasal, nasopalatine, and greater and lesser palatine nerves to provide autonomic stimulation to the mucous membranes lining the nasal and oral cavities. Other fibers, as shown here, merge with the maxillary division of the trigeminal nerve. This is going to become a common theme: autonomic fibers merging with the trigeminal nerve to reach their destination points. In this instance, the fibers will run with the zygomatic nerve within the inferior margin of the orbit, then ultimately reach the lacrimal gland through a communicating branch between the zygomatic nerve of V2 and the lacrimal nerve of V1. Here's another familiar image, back from when we discussed the sensory and motor nerves of the orbit, that will hopefully help to connect all the pieces together. As we just discussed in the previous slide, the postsynaptic autonomic fibers from the Vidiian nerve pass into the sphenopalatine ganglion, not seen in this image, and continue along the zygomatic branch of the maxillary division of V2. From here, they enter the lacrimal nerve through a communicating branch and terminate in the lacrimal gland of the orbit. Let's summarize what we've just discussed by analyzing what happens anytime we cry. Like when you get to the end of watching It's a Wonderful Life, that scene where Clarence finally gets his wings gets me every time. Again, we have this image highlighting the facial nerve and greater superficial petrosal nerve. Preganglionic parasympathetic axons originate from the superior salivatory nucleus in the brainstem, which you'll learn about more in neuroanatomy. They then course through the facial and greater petrosal nerve, through the pterygoid canal, and into the sphenopalatine ganglion. Here they synapse with postganglionic cell bodies, then hop onto the maxillary division of the trigeminal nerve, and finally through the zygomatic nerve, to the lacrimal nerve, and into the lacrimal gland. As you hear the room sing Auld Lang Syne and hear George Bailey say, "Attaboy, Clarence," these parasympathetic fibers kick into overdrive and you break out the Kleenex. For the sake of completion, I've also included the path taken by the sympathetic axons in reaching the lacrimal gland, which serve to decrease glandular secretions. It's important to remember that the pre-post ganglionic synapse happens here in the superior cervical ganglion. So even though sympathetics are found coursing through the sphenopalatine ganglion, there is no synapse in this location for the sympathetics. Moving on to the second intracranial branch that we will discuss, the Chorda Tympani. This is a later branch off the facial nerve, appearing just before the nerve emerges through the stylomastoid foramen, and it runs in a recurrent fashion towards the middle ear. To me, it looks like the facial nerve is skydiving off the middle ear, and at the very last second, the Chorda Tympani screams, "I changed my mind!" and climbs back up into the middle ear. The nerve curves anteriorly between the malleus and incus against the inner surface of the tympanic membrane. So this explains the nerve's nomenclature. Early anatomists first identified this branch in the middle ear and called it the tympanic cord for its association with this membrane. Despite this physical association, however, the Chorda Tympani provides no innervation to the tympanic membrane or to any other structure in the middle ear for that matter. It's just passing through on its way to its final destination. The Chorda Tympani then dives into the petrotympanic fissure to emerge in the infratemporal fossa. We now return to this image of the inner surface of the infratemporal fossa, which we use to explain the mandibular division of the trigeminal nerve. At the time, we mentioned that we would be returning to the concept of parasympathetics and special sensory innervation within this region, which we're now doing with our discussion of the Chorda Tympani. A few minutes ago, we talked about how the sympathetics and parasympathetics to the lacrimal gland hitched a ride onto V2 and later V1 to reach their destination. Same thing applies here. Here, we see the facial nerve descending through the distal portion of the facial canal and the proximal portion of the Chorda Tympani branching up through the middle ear. In the depths of the infratemporal fossa, the Chorda Tympani emerges and fuses with the lingual nerve and travels with the nerve to terminate in the submandibular ganglion, as well as within the mucosa of the anterior two-thirds of the tongue. So here's what the Chorda Tympani brings to the party. Off the mucosa of the tongue, the Chorda Tympani receives special sensory information in the form of specialized chemoreceptors, commonly referred to as taste buds. Whenever we eat, or put anything in our mouths for that matter, with any water-soluble chemicals, they will partially dissolve in the saliva and selectively stimulate some of these receptors in a process similar to the detection of smells by the first cranial nerve. The information received from the anterior two-thirds of the tongue travels back to the central nervous system along special sensory axons embedded in the Chorda Tympani to be perceived as taste. As with many other sensory tracts, the cell bodies can be found in specialized ganglia just outside the central nervous system. In this case, the cell bodies make up the geniculate ganglion discussed just a few short minutes ago. The other component of the Chorda Tympani is preganglionic parasympathetic fibers. As we did with the lacrimal gland, we'll paint a picture of what happens when you salivate. Take a moment to close your eyes and imagine sucking on a lemon. If you focus hard enough, you'll probably notice an almost immediate increase in the volume of saliva at the base of your mouth. What happened in part is that the superior salivatory nucleus in your brainstem sent a signal through parasympathetics within the facial nerve, which jump off at the level of the Chorda Tympani, run through the middle ear and into the infratemporal fossa, fuse with the lingual nerve, and pass into the submandibular ganglion to synapse with the postganglionic cell bodies. These fibers stimulated the postganglionic fibers that then project into the submandibular and lingual glands and increase saliva production. All that just from you picturing sucking on lemon juice. Note that these glands would also receive sympathetic innervation, in this case from fibers branching from the superior cervical ganglion and traveling with the lingual and possibly facial arteries. Nerve 7 neuropathy is of major clinical significance due in no small part to its prevalence. About 1 in 65 people will experience some form of facial nerve neuropathy in their lifetime, which is commonly referred to as Bell's palsy. Despite its prevalence, the causes are still not very well understood, and a great deal of debate still exists. Some theories point to certain viruses that may cause swelling within the nerve and compressive nerve damage from within the facial canal. It's also known that the condition is more prevalent among diabetics and pregnant women, so perhaps there is an endocrine or metabolic component. The condition may also be acute and temporary, as happens with an improperly placed nerve block for dental surgery. As the facial nerve is responsible for the muscles of facial expression, any sort of palsy would be expected to result in facial paralysis, and this is classically what we see. The patient in the accompanying diagram is being asked to raise his eyebrows and bare his teeth, and clearly this response is diminished on the right side of his face. Having gone through both extra and intracranial branches for this nerve, you should now have a sense for some of the other symptoms and treatment considerations with this condition, according to where the damage is located. If the damage is external to the stylomastoid foramen, as might be the case with mechanical trauma or parotid gland tumors, then symptoms should be limited to general motor, as already discussed. If damage occurs within the distal regions of the facial canal, the Chorda Tympani might also be infected. In this case, the patient might describe a change in taste perception and possibly dry mouth on the affected side. If the damage is slightly more proximal, the individual may have difficulty with loud noises. This is because of a branch we didn't really talk about, the nerve to stapedius. This muscle contracts to partially disarticulate the intrinsic bones within the middle ear to help buffer sounds. So without its activity, the individual is going to be more susceptible to loud noises. If the damage is even more proximal, the patient may experience eye irritation secondary to deficient tear production to coat the anterior surface. In this population, an eye patch would be prescribed until symptoms resolve to discourage drying out of the surface of the eye. Regardless of the location, you'll note that we did not cite problems with general sensation, as this is a function of the trigeminal nerve. This is an important feature of our differential diagnosis to distinguish Bell's palsy from stroke, which often present with hemifacial paralysis. Stroke will also commonly be associated with some degree of paresthesia, which is typically not seen with Bell's palsy. Okay, time to move on to the eighth cranial nerve, the vestibulocochlear nerve. This nerve leaves the cranial vault through the internal acoustic meatus side by side with the facial nerve, but once in the petrous portion of the temporal bone, it takes an alternate route and terminates within the inner ear. This is a purely sensory nerve that is actually a combination of two separate nerve branches. The cochlear nerve receives sensory input from the cochlea, or spiral organ, conveying the special sense of sound. The vestibular branch receives sensory information from the vestibular apparatus, composed of the otoliths and semicircular canals, which conveys information related to balance and equilibrium. The microstructure and function of each of these organs are pretty fascinating discussions in their own respect, but beyond the scope of the present discussion, so we won't go further than to discuss their rather short tracks. Damage to the cochlear branch would result in some form of hearing loss, whereas damage to the vestibular branch leads to feelings of vertigo, which is a medical term to describe an error in perception in which stationary objects are perceived to be in motion. This shouldn't be confused with acrophobia, which is a fear of heights. In an old Alfred Hitchcock movie from 1958 titled Vertigo, the main character, played by Jimmy Stewart, suffered from both conditions, and since that time, people have mistakenly associated vertigo with a fear of heights. These are very different and usually mutually exclusive conditions. Vertigo is typically associated with dizziness, nausea, and an interesting phenomenon called nystagmus. Nystagmus is a reflexive movement of the eyes back and forth due to rapid, coordinated contractions and relaxations between the medial and lateral rectus muscle. When a person really is spinning horizontally, these movements help the eyes to fixate on stationary objects in a person's surrounding to help maintain orientation. So you observe nystagmus naturally when you spin around. This is a nice example of the cross-wire circuitry that exists in the brainstem between three different nuclei within the cranial nerves. That of the vestibular nucleus with the oculomotor and abducens nuclei. You'll learn more about these and other circuits in a later neuroanatomy course. Next, we move on to the Glossopharyngeal Nerve. As you should recall, this is the first of three branches that leave the cranial vault through the jugular foramen, as we see in the schematic on the right. You'll notice when looking at this depiction that there are a number of communicating branches between these three nerves, as well as with other nerves that are not depicted. For the present tutorial, learning the principal branches is enough work to be getting on with, so we will not be getting into the implications of what these communicating branches mean, other to acknowledge their existence. We pick up the course of the glossopharyngeal nerve just past this foramen in the carotid sheath. It starts between the internal carotid artery and internal jugular vein just anterior to the vagus nerve. What might not be apparent when you locate the nerve in the body is a bulge within the nerve just past the foramen, indicating the presence of the inferior or petrous ganglion. This is actually one of two separate ganglion in series along a nerve. The superior ganglion is found more proximally, just before the nerve exits the jugular foramen. Both contain collections of cell bodies for sensory functions, returning from the nasoendoropharynx. As it descends, it wraps around the anterior surface of the internal carotid, emerging medial to the vessel just inferior to the styloid process. It descends on the lateral surface of the stylopharyngeus muscle, providing a branchiomotor branch to this muscle. The stylopharyngeus muscle, in fact, is the only muscle innervated by the glossopharyngeal nerve. From here, the nerve branches extensively. Many of these fibers remain in the posterior pharynx and combine with the vagus nerve to form the pharyngeal plexus. So vagus supplies the motor innervation and glossopharyngeal receives general sensory from this region. Additional branches pass through the superior and middle pharyngeal constrictor muscles to reach the mucosa of the nasoendoropharynx. The lingual branch terminates within the mucosa of the oropharynx and the posterior one-third of the tongue. This conducts both general sensory information and the special sense of taste back to the brainstem. Note how this contrasts with the anterior two-thirds of the tongue, where trigeminal provided transit for general sensation and facial for taste. A tonsillar branch passes posterior to the palatine tonsils, innervating the mucosa in the inferior nasopharynx. The most inferior branch, not shown in these images, is the nerve to the carotid sinus. It remains in close approximation with the internal carotid artery and descends to the wall of the carotid sinus. This branch receives information regarding chemo and baroreception from the carotid body located in this region. One last branch to discuss involves some additional general sensory and parasympathetic function, and much like what we've seen in the parasympathetics from the facial nerve, the path is tortuous and somewhat confusing. It involves the tympanic nerve, which is actually the first branch off the glossopharyngeal nerve. If you remember back with our discussion of the Chorda Tympani and how it seemed to change its mind at the last second and remain within the temporal bone, well, same sort of thing. But in this case, the tympanic nerve waits until after the glossopharyngeal nerve leaves the skull, then dives back into the skull. Some nerves just can't make up their minds, I guess. Here we see the glossopharyngeal nerve descending through the carotid canal, and here, branching posteriorly, is the tympanic nerve, coursing superiorly through this very small passage called the inferior tympanic canaliculus, which is found somewhere between the carotid canal and jugular foramen. Similar to the Chorda Tympani, it ascends into the middle ear, but unlike the Chorda Tympani, it will branch extensively in the middle ear into the tympanic plexus, providing sensory information to the tympanic membrane and eustachian tube. In addition, though, a terminal branch, which is now called the small superficial petrosal, or more commonly the lesser petrosal nerve, will re-enter the cranial vault through the hiatus for the lesser petrosal nerve, and will run just lateral to the greater petrosal nerve before exiting the skull once again through the foramen ovale, alongside the mandibular branch of the trigeminal nerve. Here's where we pick up the trail. Once again, we have the tympanic nerve and plexus and the lesser petrosal nerve projecting from it and through the foramen ovale, just medial to the mandibular division of trigeminal. From here, it merges with the otic ganglion and the preganglionic axon synapse with the postganglionic cell bodies. This, therefore, represents the fourth and final parasympathetic ganglion of the head. Recall the ciliary, pterygopalatine, and submandibular ganglion discussed earlier. As you might expect, especially with its close proximity, postsynaptic axons will merge with the mandibular branch of trigeminal to reach their final destination. Specifically, the parasympathetics fuse with the auriculotemporal nerve discussed in the previous lesson, which of course is posterior to the mandible, where it lies on the underside of the parasympathetics target organ, the parotid gland, which we see reflected here. The postganglionic axons will exit the auriculotemporal nerve and dive into the substance of the gland, increasing salivary production. We'll go through the parasympathetic path one last time, but in this case we'll use more of a schematic representation. The path from the glossopharyngeal nerve to parotid gland has too many ins and outs to show in a single view. In this instance, preganglionic cell bodies originate in the brainstem in a region you'll learn about in neuroanatomy called the inferior salivatory nucleus. Preganglionic axons merge with the other components of the glossopharyngeal nerve and exit through the jugular foramen. They course into the tympanic nerve with general sensory fibers and pass through the tympanic plexus to form the lesser petrosal nerve. From here, they pass through the foraminal valley to enter the otic ganglion and synapse with the postganglionic cell bodies. Postganglionic axons then pass out of the otic ganglion into the auriculotemporal nerve and finally pass into the parotid gland through short communicating branches. Parasympathetics from the glossopharyngeal nerve, therefore, produce salivation exclusively within the parotid gland. A bit of a mess up system when you think about it, considering the fact that the other big salivator, the facial nerve, passes right through the damn thing. One final note on the sympathetics to the parotid gland. As always, these love to travel with arteries to reach their targets, and we have this middle meningeal artery coursing right through the auriculotemporal nerve. So the postsynaptic sympathetic axons from the superior cervical ganglion jump off the middle meningeal into the otic ganglion and travel with the parasympathetics for the remainder of their course to the parotid gland. As always, note that the sympathetics pass through the otic ganglion without synapsing. As you might expect, damage to the glossopharyngeal nerve will affect salivation from the parotid gland, but seeing as each of these glands is responsible for only about 12% of salivary volume, this may go unnoticed. The most noticeable sign and symptom is altered sensation towards the back of the mouth, including with taste along the posterior tongue. Next, we move to cranial nerve 10, the vagus nerve. It gets its name for the vagrant or wandering path it takes as it moves through the thorax and abdomen. For the sake of time, we'll limit our discussion to branches within the neck. The inferior portions were discussed in great depth in the thoracoabdominal sections of this course. As we saw with the glossopharyngeal nerve, the vagus nerve emerges through the jugular foramen, bound in the carotid sheath between the internal carotid artery and the internal jugular vein. As it descends, the principal vagal trunks pass medially posterior to the carotid artery. Like the glossopharyngeal nerve, there are two ganglia associated with the vagus nerve. The superior ganglion contains cell bodies related to general sensation from meningeal and auricular branches that arise prior to the vagus's exit from the jugular foramen. The inferior ganglion, also known as the nodose ganglion, contains cell bodies related primarily to visceral afferent sensation. The first major vagal branch observed within the neck is the pharyngeal branch. It emerges off the vagus nerve just past the inferior ganglion and branches extensively as it blends with the middle constrictor muscle. This forms the vagal contribution to the pharyngeal plexus and provides motor innervation of all the muscles of the pharynx, save for the stylopharyngeus, which, as previously discussed, was innervated by the glossopharyngeal nerve. Some of these branches wrap around the constrictors to innervate most of the muscles acting on the soft palate. The other branch found in this area is the superior laryngeal nerve, which itself divides into two additional branches. The external branch contributes to the pharyngeal plexus, but also sends a deep branch to the cricothyroid muscle, shown here. Note that we do not see the neural branch itself, which approaches the muscle from the anterior side of the pharynx. The internal branch is purely sensory, supplying the mucosal superior to the true vocal folds. Finally, note the presence and location of the recurrent laryngeal branches of the vagus nerve. These seem to pop up in every single unit, don't they? In this instance, we observe their termination within the larynx, inferior to the ventricle, separating the true and false vocal folds. This creates something of a neural boundary. Whereas the internal branches of the superior laryngeal nerve receive sensory input from the mucosa superior to the true vocal folds, the recurrent branches receive sensory input from the mucosa inferior to these folds. Also remember that the recurrent branches are responsible for motor innervation to the remainder of the muscles within the larynx, and that damage to either left or right recurrent laryngeal nerve, anywhere along their paths, will lead to hemiparalysis of the vocal folds on the ipsilateral side of the body. We'll talk more about some clinical implications of damage to the vagus nerve in a moment, but first we'll review another nerve that we've seen time and time again. The spinal accessory nerve first appears in one of your first dissections with reflection of the trapezius muscle. At the time, it was difficult to trace the nerve to its origin, but now we can complete the picture. This is the third and final cranial nerve to emerge from the jugular foramen. As it emerges, it immediately migrates laterally, typically just anterior to the internal jugular vein. We can see a small bit of it here just distal to the jugular foramen. Here's a view that you are probably more familiar with as far as the spinal accessory nerve goes. We observe the accessory nerve descending through the posterior triangle of the neck and, of course, the two muscles it innervates, trapezius and sternocleidomastoid. I've held off a bit in discussing many of the pathologies associated with damage to these nerve branches in the head and neck because, in many instances, they are not isolated events. Because of the close approximation of these structures to one another, an event that affects one nerve will commonly affect the other branches as well. A prime example of this is jugular foramen syndrome. It's a blanket term used to describe a variety of conditions that lead to compression of the structures in and around the jugular foramen. The most common cause is tumors either within the neck or inferior cranial vault, but trauma, infection, and bone disease may also lead to this syndrome. As you might expect, the glossopharyngeal, vagus, and accessory nerves are all affected to varying degrees. One of the most common findings is dysphagia, which is difficulty in swallowing. This is because of neural cooperation between the glossopharyngeal and vagus nerves in the pharyngeal plexus. As food hits the back of the throat, involuntary contractions take place to move the food down through the esophagus. Any disruption within the glossopharyngeal or vagus nerve, or the central integration circuits, has the potential to create difficulties with this reflex. Note that this relationship is also responsible for the gag reflex, in which stimulation of certain regions of the mucosa of the oropharynx induces gagging or vomiting. You're probably familiar with this reflex if you've read anything about the eating disorder bulimia, in which individuals will often stick their fingers down their throat to induce vomiting after a big meal. As part of a diagnostic workup to test either the glossopharyngeal or vagus nerves, a physician may touch the mucosa towards the back of the throat to test this reflex. Loss of this reflex is indicative of an issue with either or both of these nerves or in the reflex arc. A further indication of damage to the glossopharyngeal nerve is if the patient reports altered tastes or sensations at the back of the throat. An additional indication of damage to the vagus nerve is in relation to altered phonation, or speech. The vagus nerve is responsible for innervation of the muscles of the larynx and control the vocal folds. Damage to one of the vagus nerves would therefore result in vocal hemiparalysis, resulting in dysphonia or hoarseness when trying to speak. The physician may also notice a deviated uvula and asymmetry within the soft palate as a result of paralysis of the muscles innervated by the vagus nerve in this region. Involvement of the spinal accessory nerve would result in paralysis to the sternocleidomastoid muscles. This would result in obvious asymmetry in muscle tone, depression of the affected shoulder, and possible scapular winging as well. This brings us at long last to the 12th and final of the cranial nerves, the hypoglossal nerve. The nerve passes through the hypoglossal canal posterior to the carotid sheath. It then passes between the internal carotid and internal jugular vein and runs inferior to the posterior belly of the digastric muscle to enter the submandibular triangle. The hypoglossal nerve then runs along the lateral surface of the hyoglossus muscle on its way to the tip of the tongue. The nerve is responsible for innervation for all of the intrinsic muscles of the tongue save the palatal glossus muscle, which is innervated by the vagus nerve. These muscles are responsible for a number of different tongue motions, including protrusion of the tongue from contraction of the genioglossus muscle. Consequently, hemiparalysis of the hypoglossal nerve becomes noticeable when the patient sticks his or her tongue out. The lack of contraction from the affected genioglossus muscle causes an imbalance in the muscle pull, and the tip of the tongue deviates towards the affected side. Also note the muscular wasting on the affected side, an indication of a long-standing nerve injury. Damage to the hypoglossal nerve can also occur with jugular foramen syndrome, as well as with surgeries in the neck region. We're just about ready to wrap things up, but first, one final look at a posterior view of the carotid sheath to distinguish some of these tightly wound nerve branches. First, let's highlight a bit of the internal carotid artery and internal jugular vein that we have here to give a bit of perspective. Next, we'll start adding in some of these nerve branches. We'll start with the Glossopharyngeal Nerve in green, vagus in gold, the Spinal Accessory in purple, and finish off with the Hypoglossal in brown. While we're at it, we should include one last big player in this picture, the sympathetic trunk with the superior cervical ganglion and its close approximation to the internal carotid artery. We've spoken at great lengths about sympathetics that accompany the parasympathetics into the head, so it only seems fitting that we identify this structure and talk about its clinical significance. Damage to the sympathetic chain anywhere along its course will result in loss of sympathetic innervation to the head and neck. This results in a condition called Horner syndrome. Common causes are, once again, tumors in the region of the neck or from inadvertent surgical transection during a carotid enterectomy to remove plaque buildup on the inside of the artery. Symptoms of this condition result from a loss to sympathetic innervation, ptosis of the eyelid, a constricted and unresponsive pupil, dry, flush skin due to lack of sweat production, and excessive production of tears and saliva. All right, that wraps up this rather lengthy review of the last 6 cranial nerves. I sincerely hope you found this tutorial and the others in the series beneficial in helping you learn the cranial nerves and autonomic innervation to the head and neck. Once again, if you found this tutorial helpful, you can help me out by clicking the like button at the bottom of the screen and by subscribing to my YouTube channel to keep a lookout for future videos. You can do so in the comment section below, but you're probably better to email me with any questions you may have, as I probably won't be checking these videos regularly. Anyone's welcome to contact me, whether they're a UB student or not, with any requests for future podcasts that you would like to see added to this channel. So until next time, this has been Dr. Stuart Ingalls. Enjoy the rest of your day.